I wanted to say good morning to everyone and happy CDI week. I'm so happy to be here with you. And I hope that I'm wondering whether I really should have titled it CDI and ED where inpatient meets outpatient, but they meet each other. So we're just going to have to go from there. As Lee kindly introduced me, I was an emergency physician for 25 years, and I practiced clinically while I was becoming a physician advisor for a period of time. So a lot of the things that I'm going to be talking about, I was able to put into practice while I was in the emergency department. So I'm hoping that other people you can get other people to do it as well. So when I first became a physician advisor, I realized that the pot at the pot of gold at the end of the rainbow was getting the emergency department to do it right, so that they would set everything in motion. And so I really just wanted to be able to show you this really cool picture of a double rainbow I got, but we'll move on. These are our objectives, and what I really am going to try to do is get you to get your ED folks to do better documenting. And one of the reasons why I thought it was so important to be able to make sure that the emergency department got this right is because there are times that the only provider who sees the patient, a critically ill patient, is the emergency department. And so what happens if a patient dies before they ever make it upstairs to the unit or before somebody else ever sees them in the unit, if the emergency department didn't do a good job documenting, all of the additional diagnoses will get lost. So, doctors have heard the expression forever that if you didn't document it, you didn't do it. But is that really true? Well, no, it's not really true. But what happens is the emergency department, a lot of patients are the sickest they're going to be when they're in the emergency department. And they get treated aggressively. And by the time they get upstairs, they've improved. So like pulmonary edema or loss of consciousness. If it's not documented in the emergency department, it may be lost to the entire encounter. And so it's really important to get the emergency physicians to do it right. Well, why is CDI in the emergency department so different? Well, there's multiple reasons. So there are lots of time constraints in the emergency department. So the expectation is that the patient is going to be seen quickly, addressed quickly, and if they need to be admitted, they're going to go upstairs quickly. And if we don't make sure that what needs to be done is done in the emergency department, it may not get conveyed upstairs. And the expectation in this electronic age is that by the time the patient hits the floor, the note should be available for looking at. So the days of when we used to batch and do all our documenting at the end of the shift are supposed to be gone. And that's actually a really good thing because it improves patient care as long as the doctors are actually capturing what happened. Patients are seen simultaneously as opposed to sequentially in the emergency department. The folks that actually work in the emergency department are often not employees of the institution. So sometimes it could be a group that's being employed by the institution, but the doctors are not beholden to the hospital, they're beholden to their group. And so what happens is it may be hard to get a hold of them if you're not there during their shift because they can't be found anywhere else in the hospital. There are lots of providers who work a shift here and a shift there. So it may be that if it's not the kind of thing where if you have a hospital, actually it's similar to a hospitalist. Sometimes you'll have a hospitalist that works 7 days in a row and then they're off for 7 days. So if you don't catch them while they're working, it's hard to catch them until the next time they come, which may be more than a week later. It's similar in the emergency department and you may not even know when they're going to be there. Emergency physicians often don't use the hospital email, and there may not be a very good way to contact them and to catch them when they're not around. And they may not have a really good mechanism for having staff meetings and so on with robust attendance. There's always somebody working in the ED, so you can never get everybody at the same time. So although 15 to 35% of emergency patients are admitted, and another 15 to 25% of the initially outpatient status for observation service patients, they get converted to inpatient. The majority of ED patients are outpatients, and they do get discharged. So the documentation is really important to make sure that you get inpatient metrics correctly, and so that you make sure that you get the outpatient documentation appropriate as well. But what you have to realize is the hooks that you have for inpatient doctors, so like I really want to make your quality metrics look good, often don't really have anything to do with the emergency physician because the metrics are usually not theirs. So what the emergency department does is help or hurt the inpatient metrics, but it's not necessarily reflected on them. But one of the things that you can do to kind of hook the ED docs, or at least their group, is that you may be able to say if there's a group that's employed, you may be able to say to them, this is how we're going to judge your quality, and this is how you're going to get retained. So it's really important, if the emergency group understands the importance of optimizing the metrics in hospital reimbursement, their value to the hospital is increased, and they're likely to be retained. But remember, they're not that easy to get if they're off shift. So you may really need to adjust how you do your CDI. One of the other things that's really different about emergency physicians is we are really adaptable. So we just roll with the punches. We're like Angus MacGyver. If you tell us that you don't have a certain kind of tool, or you don't have, we don't have that kind of doctor here in this institution, we have to figure out another way. Moderator, can you please mute everybody else but me? I'm hearing a lot of background noise. I'd appreciate it. Thanks. So, in the emergency department, we take whoever comes through the door. If we don't have what we need, we improvise. And practically, what that means to you is if you go to the emergency physicians and you say to them, I need you to use this terminology instead of that terminology, most of the time, their answer will be like, all right, whatever, because they're used to doing things like that. I am really going to be focusing a lot on the CDI that has to do with the inpatient perspective, because the outpatient risk adjusting models like the HCCs, although they're really important to be captured, the ED environment is not ideal for really carrying. Yeah, I think muting me is not in the best interest. I think what we need to do is mute everybody else. Thanks. So although HCCs are important to be captured, the emergency department folks are not the ones who really are meant to be characterizing the chronic conditions. But if the emergency physician lives by that cardinal rule of making the patient look as sick and complex in the medical record as they look in real life, all your risk adjusting models, including the HCCs, should be served. So when I was an emergency physician, like I said, at the end of my clinical career, I worked as a physician advisor and an emergency physician at the same time. And after my orientation for being a physician advisor, immediately my patients became sicker. And the reason was that Kelly Scareppa, who I know is listening today, and Chris Bates sat down with me to give me my orientation, and they taught me several conditions that really I had never thought about before. So number one, they taught me about using the word encephalopathy instead of altered mental status. They taught me about severe protein calorie malnutrition. And if I, as an emergency physician, like, malnutrition is not my thing, but if I see a patient who looks like this, it doesn't take a rocket scientist to know that this patient has severe protein calorie malnutrition. And the third one, which I often use as my example to doctors, and I know that my friend Jim Kennedy, who's listening today, doesn't agree with me on this one entirely, is that I really like the term functional quadriplegia. So functional quadriplegia is really a coding construct. It's not a clinical condition that we doctors are taught when we're training to be physicians. But what happens is I know that a patient who's like this is sicker than a patient with the same underlying urinary tract infection who doesn't have the inability to take care of the ADLs, who can't feed themselves, who gets dehydrated because they can't drink for themselves. They can't cough well, so they get aspiration, and they have an indwelling. They have a feeding tube and an indwelling Foley. They get aspiration pneumonia, and they get catheter-associated complicated urinary tract infections. This patient with functional quadriplegia is sicker. And when I was taught the expression functional quadriplegia, it gave me verbiage. It gave me terminology that explains why this patient is sicker, and I really welcomed that. And I think that if you approach your doctors in a way that they understand, not like eye roll, this is just something that coders are making you do, but this will help you describe your patient and take care of your patient, you will have more success. So the reality is that emergency physicians, like most physicians, get training on how to document to support their professional fee, so their evaluation and management level of service, and how to document for the lawyers. But the reality is that what documentation is really for is for clinical communication. And if we can get the doctors to be able to do that well, they'll at least give the CDI professionals the baseline for being able to give you what you need to be able to make sure that the patient seems accurately as sick and complex as they are. So documentation, especially in the emergency department, needs to do 4 basic things. Now, the first thing, which some of you may not be aware of, is the first thing it's got to do is it's got to demonstrate that you meet medical necessity. Because the reality is, if you don't support medical necessity, if there is no medical necessity for the visit, there is no billable service. So you do not get paid if there is no medical necessity for the patient to be there. And I'm going to talk about this in a second. Next thing, most important thing, is that clinical communication that I've discussed. We need to support the billing, and then we need to be able to demonstrate the quality of medical care. So medical necessity is basically, would someone think that the services or supplies used to take care of that patient with that problem in that setting were reasonable, appropriate, and met the standard of care? If the answer to that is no, then the patient is either not supposed to be in the hospital at all, or they may be in the wrong status. So what happens is a patient gets admitted either as inpatient, or they are what we call observation, is really an outpatient status being given observation services. And what happens is the most important thing to do to avoid a medical necessity denial is to make sure the patient is put in the correct status. The next most important thing is to document it so everybody else can tell that they're in the right status. And so they look at the diagnoses and they want to know, do they make medical sense and do they support the status? So the kind of things that put a patient into medical necessity peril for denial are listed here. So observation services are really intended for patients who are too sick to go home, but it's not clear whether they need to be admitted or whether the condition is going to reverse quickly and they'll be able to be discharged. So inpatient status is for patients who are too sick for observation, and especially when you're talking about Medicare patients, the condition is likely to take more than 2 midnights to resolve for safe discharge. So what happens is, if you're sitting on the fence, then the most prudent course is to place the patient in that outpatient status for observation services, which I'm going to call observation from now on. So the most prudent course is to place them in observation, let the condition declare itself, and then if you determine that they can't be discharged, then they should be admitted. It should be converted into an inpatient admission. And so what happens is diagnoses which clearly need documentation to provide if you have a diagnosis which usually turns around quickly, but you think that this patient, for some reason, needs to stay in the hospital this time. So conditions like CHF or hypertensive urgency or COPD or asthma, those are patients who usually turn around quickly and can usually go into observation. But if you have extenuating circumstances, you need to document them. So we need to get the doctors to document the extenuating circumstances so that the third-party payer doesn't say, hey, they only had CHF, they could have gone to OBS. Diagnoses which have an insidious course often need to be outpatient. So often you don't treat a cellulitis inpatient because it takes a really long time, and it's often more of an indolent course. But if you have a reason why they need to be admitted this time, you need to let them know why. Unspecified diagnoses, which often are done in the emergency department, so usually either use signs or symptoms or you use unspecified diagnoses because in the ED they're not sure what it is yet. You need to explain why the patient is sick. And then if you don't document those comorbid conditions, those are also patients who the third-party payer looks at and goes, why were they admitted? Well, you as a CDIS and the doctor know, well, they had diabetes and they had this and they had that and they had this. Yeah, but you didn't really document that you were taking care of those things, so they're not really entering into the calculation. So one of the other things that you need to make sure that your doctors are doing, and it may be that you as CDISs are being recruited to help the utilization review case management folks. And so one of the things in the emergency department you need them to do is get them to explain why they have that realistic event expectation of greater than 2 midnights. So sometimes we'll have an attestation that says, patient needs to be admitted because they have greater than 2 midnights. You got to tell us why. If the patient has severe signs and symptoms, document that you should have the doctors document that I think that the patient is at risk of this adverse event if we don't admit them because. If they should document that the testing and treatment will not be safe to be done on an outpatient basis. And then you may or may not be aware that there are these clinical decision tools called Interqual and MCG. And what they are really like clinical criteria, but they're guidelines. They're not really clinical criteria for the physicians. What it is the deniers needed to have some mechanism for the people who are the reviewers to be able to judge whether or not a patient is sick enough for whatever status you put him in. So they created these criteria. And what happens is they have all sorts of, you can't go to the doctor and say, well, they don't meet the MCG criteria, so they have to be put in observation or discharged. The reality is if they don't meet the criteria, then the doctor needs to document why. And so that's your job, is to get them to document robustly so that it's clear. So here's some examples. So you want to use an uncertain diagnosis that makes admission sense. So if in your head you're thinking abdominal pain, I want to make sure I rule out that it's a bowel obstruction, they shouldn't be documenting abdominal pain, probable constipation, because a payer is going to look at that and go, they don't need to be admitted for constipation. Why are you admitting them? Use an uncertain diagnosis that makes the admission make sense. Teach your providers to use strong adjectives. So what I do is I will look at the MCG criteria or Interqual criteria for that diagnosis, and I will look and see what words are they using. Severe, unremitting, acute, persistent, intolerable, unstable. Then have them mirror those adjectives in their documentation. And then the doctor needs to explain their thought process. Why is this patient sicker than the average bear? What do the doctors need to learn? We're going to go over all of these. So I just made you like a summary list. So we're going to go through, this is what we're going to go through now. And then I'm going to go through each one of these in the next slides as well. But this is, again, a summary slide for you. So you want to have the ED providers try to make a diagnosis. Their choices are a definitive, right? Or they can do an uncertain diagnosis, or they need to use signs and symptoms. Now, we all know that we hate signs and symptoms as a DRG, but sometimes in the ED, you just don't know what it is yet, so you need to use the signs and symptoms. But you can teach them to marry the signs and symptoms with an uncertain diagnosis, because in case the patient dies on the way upstairs in the elevator, if they said abdominal pain, rule out mesenteric ischemia in the bottom, because that's what they really think it kind of is, but they haven't figured it out yet, then they may end up in the mesenteric ischemia DRG, right? So I teach the doctors, I don't want them to wildly speculate. This isn't every single thing make something up that it could be. This is, if you really think that it could be something, use an uncertain diagnosis. And then I teach them, obviously, that if it isn't ruled out by the time of discharge or demise, that it gets coded, because they don't know that. On the professional fee and in outpatient encounters, that's not the case. They only use the signs or symptoms. The rule out, possible, probable, suspected goes completely away. Okay? In the emergency department, and anywhere, but in the emergency department particularly, it's especially important to make sure you have a diagnosis that corresponds to any procedures or any abnormal finding. So, for instance, this is a patient that had a fall with a left ankle injury, and they had x-rays of their neck and left ankle because they had atrial fibrillation, rapid ventricular response, which made them woozy, and then they fell, and then they sprained their ankle, right? But if the only diagnosis that you have is atrial fibrillation, rapid ventricular response, there is no medical necessity to do an x-ray of your neck and left ankle for atrial fibrillation. So you need to at least have something that gives them an understanding as to why they did it, so they can meet medical necessity. Left ankle pain, or neck pain, or status post-fall, something. And then in the bottom one, you want to make sure that you have something. So it could be, you could use right ear discharge, rule out suppurative right otitis media. But you found yellow-green ear discharge. So it's not only that you need to do the medical necessity for the culture that you sent off, but you also don't want the people upstairs to miss the fact that this patient may have a suppurative right otitis media, and they're only looking at the fever and the bacterial pneumonia, and they completely missed that boat because they didn't look in the patient's ear, but you did. So you need to make sure that your doctors take credit for whatever they do. And then this is something that I try to teach doctors. They don't have to do it this way, but to me, as a physician, the acute exacerbation of the COPD is the most important thing. The fact that the patient is acute on chronic hypoxic and hypercapnic respiratory failure due to this acute exacerbation of COPD and the fact that they have bronchopneumonia, the respiratory failure is the most important thing. I like putting the most important thing there because I want people upstairs to know how I was organizing it. Now, I don't really think that doctors should be choosing principal diagnoses. I think that that's really the coder's job because the doctors don't know the rules, but they can telegraph to the subsequent providers what they think is important. And so down on the bottom, the acute exacerbation of the heart failure and hypoxemia is important, and the fact that the patient had syncope. And then, since they had syncope, they had forearm and right arm abrasions. So what you want to do is put the most important thing first and then put everything else that comes after it. And I try to tell them, I want you to be telling a complete story. So on the left, these are the kind of things I see all the time when I'm doing chart reviews. So on the left, the patient has a stroke. Yeah, they do. But on the right, these are the diagnoses that I, as a clinician, would have documented. And it's the same patient. But doesn't my set of diagnoses give a much better, deeper picture of that patient and how sick and complex they are than the one on the left? And I literally would do this in the emergency department. I would be thinking to myself, it would help me organize my thoughts. I would think to myself, what's going on? What has caused it? I don't know if Jim's going to talk about his music mnemonic, but I would think to myself, what caused it? What occurred as a result of it? What other things were comorbidities? That's how I practiced medicine. And then I would do my documentation to express the important pieces and parts that I just went and thought about. And my motto is put mentation back into documentation. So I want to make sure that everyone knows what I was thinking. And sometimes I would really be trying to help them think and organize their thoughts upstairs. On the bottom, this is something I learned to do, and you might want to try to teach your doctors to do it. It's not necessary because patient conditions that are found in the emergency department are by definition POA, but I used to specifically put it there because I started learning which conditions could serve as hospital-acquired conditions or HACs. And so when I found one like a sacral decubitus, I would just write POA because that made it clear. Nobody ever had to go and query anybody, do you think it was present on admission or not? There it was. This is something I do, and I'm going to teach you this thing so that you can teach your doctors to do it if you want. I show them this, and I say to them, if I tell you the answer to this is 3, do I get full credit? And somebody will say no, and I'll say why? And I'll say, because you didn't. And then they say, show your work. Some of you are home right now and schooling your kids, right? They need to show their work. Well, then I say to them, well, what if I have ADD and I show all my work, but when I get to the end, I never tell you the answer is 3. Do I get full credit? And the answer to that is no as well, right? Because you need to do both. And so what I say to the doctors is, some of you are really good at showing your work, and then you never tell me the punchline. And so, the coders have rules, and they need certain verbiage to be able to do it. They are not allowed to make inferences. They can't make a leap from sodium of 128 to hyponatremia. Because what if the glucose is, 654? Maybe it's not really hyponatremia after all. Maybe it's pseudo-hyponatremia. We need the clinician to tell us. So I tell them, don't describe, ascribe. This is another one, a mnemonic I use, and you have to forgive my really pathetic Cockney accent, but I say to them, listen, I know it's a real asshole, but I need you to give me acuity, severity, specificity, and linkage. So those are the pieces and parts of documentation of describing conditions, which may give you different codes, right? It may take you from an unspecified code to some acute version. Severity often doesn't have any, sometimes it does, but it often doesn't have any contribution to the coding, but it still telegraphs information to the next caregivers. So I think it's important. And then specificity and linkage, of course, are really important. So as I was saying before, conditions diagnosed in the ED are considered POA. And then you want to make sure that as the patient goes upstairs, that you train your doctors to do what I call evolve, resolve, remove, and recap. So they document something in the emergency department, so that's when it's first diagnosed. And then upstairs, you need to get them to continue to document it as it's being treated. When it resolves, I often like removing it from my list, but some doctors like leaving it on there because they want to remember that it existed initially. And then I say to them, they need to put it down at the bottom of the list and write resolved. And then it should reappear in the discharge summary. So the best practice is always for the diagnosis to appear at least 3 times in the record. And if it started out in the ED, that's at least 1, right? And then sometimes people will say to me, well, if it's only in the ED, is it still codable? Can you, did it still exist? The answer is yes. But that's why it's really good to get the doctors upstairs to say the patient was in acute hypoxic respiratory failure in the emergency department. They treated them aggressively. It took 4 hours for them to come upstairs. They're no longer in acute hypoxic respiratory failure, but we are still treating the pneumonia aggressively, whatever. Okay. So then certain diagnoses should be, they should be thinking about the ones that are that can be hacks are things that you really should have the emergency department put in a mechanism to really routinely screen for them. So if a patient has infections, you should do a sepsis screening. if patients have reasons why they might have pressure ulcers. So, for instance, they're morbidly obese and they have lots of redundant skin folds, or they're malnourished, or they have functional quadriplegia, or they just had a 3-week admission for COVID and they were prone, you want to make sure you do a routine skin check, because if you pick up the pressure ulcer in the ED, it's POA. And then if they happen to be queried, so I know most of the time you go to the hospitalist, but if you happen to go to the ED folks, and I actually believe that querying in the ED is a good option for certain things, but you want them to understand that there's that option of W, which is clinically unable to determine. So that is something that you want them to know, that if you're not sure, it's okay to say, we're not sure whether it was present on admission or not, because that actually gets counted as present on admission. And then if there are medication, surgical, or device complications, I often like those POA, because those may establish the DRG. And then mortality, I showed you that picture of somebody dying in the elevator on the way upstairs. So what happens is when you have your mortality metrics, the rankings, most of those conditions need to be present on admission to be entered into your observed to expected risk adjustment model. So I like having them picked up early. So these are the kind of things where when we used to do mortality review conference, they would say to me after a 6-day stay and the patient ended up dying of, what looked like pneumonia, and they would say to me, well, wasn't this sepsis when they were admitted? And I'd look, and to me, it looked like it was sepsis. I wasn't there, of course, so I can't really say for sure. But I wouldn't want to go query for sepsis, because if you didn't document it while the patient was in the hospital, and then you do it after the fact, then you lose the opportunity to attend to your sepsis core measures. And, it's like squeezing the balloon. You may have fixed mortality, but you've now caused yourself to have a hack or a patient safety indicator, or you fall out of a core measure. So it's really important to make sure that you're attending to everything. And so these are some conditions that specifically I would try to train your providers in the emergency department to capture present on admission. Because, they think to themselves, oh, yeah, so what, they've got hyponatremia. Like, that's not something I need to really mention. It's really more important that they have X, Y, or Z, which is the main reason they're being admitted. But the reality is, if the patient ends up dying, that hyponatremia in the emergency department, POA, is really important, because it's risk adjusting for the mortality model. Okay, so if we were together, I would be saying to you, what kind of things would you want to see on the general appearance of the physical examination? Because to me, this is like one of the most important things. So what happens is, if you have patients who are sick, but the doctors document them like they're on the right-hand side, then it sets up an internal inconsistency. So if you have a patient who you make the diagnosis, who the doctor makes the diagnosis of sepsis, but what they've said is the patient looks non-toxic, they're alert and oriented ×3, and no acute distress, but then their conclusion at the end is sepsis, it's incongruous. Okay? So, one of the places where this comes from is providers being overly reliant on macros or templating without doing active, mindful editing. So I would say that it's important for CDI to be involved in making templates and macros, because you want to make sure that they don't set this up to fail. So this is what I did when I was working in the emergency department, but being a physician advisor. I made myself this mnemonic, and I teach this to doctors. And if you have the courage, you are welcome to teach to them too. What I do is I would go brain, heart, lungs, organ circulation, code status. And so this was how I, in the emergency department, would try to run through the list of things that often, most of you will notice when we go to the next slide, serve as CCs and MCCs, because they're risk adjusting, because they're important. So what happens is I'm not going to actually go over these with you right in this talk, because you know what? You know most of these, right? So I don't really need to teach you this, but I'm telling you that these are the ones that you see in the emergency department more often than others. And so when I go brain, heart, lungs, organ circulation, code, status, these are the things I'm thinking. And so when I was putting the mentation into my documentation, I would think to myself which things were present, and I would document them. And so how do you do your CDI in the ED? So first you need to make sure you introduce it, because I got to tell you that, you know, there are people upstairs who don't know you exist, but the people in the ED certainly don't. So you want to make sure that you're introduced to the administration and the providers, and you want them to understand that you're trying to help them demonstrate how sick and complex the patient is. Unfortunately, you can't focus on metrics with them because they don't reap the rewards, like I said. If they work in a group that's employed, you may be able to say to them, you know what, our hospital really cares about our bottom line, so this is important, but that's more of an administrative, like that's not going to work with the providers. But basically with the providers, if you can get their administration to buy into it and get you in front of them, they may just do it because someone asked them to. So they just kind of do what they're told. Somebody says there's a new core measure and you guys need to do this from now on. They go, okay. So give that a try. I would suggest everybody have some sort of a really quick elevator pitch to explain to people what you do and why you do it. This is mine. I tell people and it's funny, I have a 90-year-old father who's got pretty significant dementia. And I've told him this often enough that if someone asks him what I do, he says she teaches doctors how to document, because that he's heard it enough times he remembers. So I say I teach doctors how to document so they get credit for taking care of as sick and complex patients as they do. If they take excellent care of their patients and document well, quality metrics and reimbursement are optimized. I don't use maximized because I don't believe in maximizing. I believe in optimizing. You should get appropriately compensated and your quality metrics should be where they belong. And denials are averted. And then you folks in the ED are critical to getting this right. People really like being needed and wanted. So you could tell them that they are so important to us, and that may make them want to do it for you. So where can how can you do it with the emergency physicians? Some of it is the same as anywhere else in the hospital. Emergency physicians do have staff meetings. Not everybody is there, but some people will be there. And if you go regularly, eventually you'll get everybody. They often, if they have a residency program, they have conferences. You can have lunch and learns. Everybody likes being fed, especially in the emergency department, I can tell you that. Impromptu small groups. So I would just walk through the ED and just, grab, if people were sitting in the fishbowl waiting for the next patient, I would go over something with them. And then one-on-one, you could just sit with a doctor. And I used to do this, we did elbow rounds up on the floor, and I would do this in the emergency department. I would just sit with them. And then I'd have them present the patient to me. And when they said, the patient has altered mental status, I'd say, tell me a little more about that. And they would tell me a little more about that. And that would be an opportunity for me to teach them about encephalopathy. And then they could go, yeah, you know what? Actually, that really fits. They have metabolic encephalopathy. Right there, I've done it. Now, if you do it, if you don't tell them what to do, you can actually take credit for it as being a query if you so desire, and if that's how you guys want to, set up your how you're judging the productivity. And then the other thing you really need to know is who to send them to if you don't know the answer. So I got to tell you that when you work in the ED, a lot of the questions you're going to get are going to be on medical necessity. Should this patient go into observation? Do I need this for critical care documentation? You may not know the answer to that, but know who you can refer your doctor to, or go learn some of that stuff so when they ask you, you can help them. Because if you help them, they're going to want to help you. Okay, so the written queries, you need to figure out the right mechanism to notifying them, because if they're not using the hospital email, that may not be the way. It may be that in your EHR, there's a way of sending them messages, or there's some mechanism, and that may be it. Then you need to teach them to use it. Concurrent face-to-face sessions work really well, but remember, like I said before, you need to figure out a way to make sure that you keep track and take credit for queries. It's always lovely to do verbal queries because there's none of that lag of doing the query, waiting for the response, and then having to go back and ask them again, etc. Okay, so I'm going to go over some specific conditions, and the first is going to be cardiac arrest. So, it's interesting. I've been reading about what's going on in COVID since I'm not practicing, and what I hear over and over and over again from ED physicians is they have never seen so many people die during a surge as in their whole life. So that, they basically say in one shift, they may see more people die than they have seen in a year before. So it doesn't happen that often, but it does happen more commonly in the ED than up on the floor, and probably anywhere other than the ICU. So this is interesting. I wouldn't have thought that the first bullet point here was a controversial situation, but I asked around, and there were, when I was writing an article on this, I found that there are folks who don't code cardiac arrest if it's resolved by the time the patient arrives at the emergency department. So Coding Clinic actually has a ruling that cardiac arrest does get captured inpatient if they get resuscitated. But then, of course, there are exclusions if the patient is not discharged, if the patient dies. But the point is, you can't, on the pre-hospital side, I still think it needs to be coded. It's still part of this encounter. If that's what brought the patient, brought the ambulance to the patient, brought the patient to the hospital, it's not history of cardiac arrest. It's still part of this encounter. Kind of like syncope, if you think about it. If a patient presents and they're conscious after they had a syncopal episode at home and the provider didn't witness it, they still document it as syncope and it still gets coded. So it's the same thing as cardiac arrest. Now, in the emergency department, this is usually not an issue because, when we see cardiac arrest, we don't know what it's from. But every once in a while, there may be something where we really get a strong suspicion. So the patient was, short. They have a malignancy. Their right leg has been swollen for 2 days. They were feeling very short of breath. They walked to the bathroom and they went, "Oh my God!" and they, passed out. And it may be that you have some sort of an uncertain diagnosis. So that will actually establish the cardiac arrest code. So if they can do that, that's great. But I don't think that's something that you need to really spend a lot of time teaching them. I do think that the providers should run through whatever they need to do to their Frere Jacques mnemonic or whatever to think to themselves, are there other diagnoses that require workup or treatment, not just the cardiac arrest piece of it? And then were there any complications as a result of their having a cardiac arrest, like rib fractures or something like that? Okay. So have you ever wondered why your institution does trauma when a lot of these trauma patients are under or uninsured? When I was still working as a physician advisor, we actually became a trauma center. And I was wondering, why? And I talked to my friend who is the chair of emergency medicine, and he said, this is why. So what happens is, that your hospital has their case mix index. Well, when you have highly weighted DRGs, it increases the case mix index. Multiple significant trauma is a very highly weighted DRG set, especially the surgical ones. And so the quality, there are quality and financial implications to having a higher case mix index. And this is why most hospitals accept the trauma designation. Oh, yeah, and they want to save lives. Okay. All right. So to get into the MDC 24, the multiple significant trauma MDC. There are a couple of ways. I'm going to tell you that I don't exactly understand this because one of the ways, which is the top one, you have a principal diagnosis from the trauma diagnosis list. And if you look at it, it's got things like bug bite. Well, if you've got two significant trauma body site category conditions, the likelihood of having a bug bite as your principal diagnosis and then a femur fracture as a secondary diagnosis is pretty low on my list. But it could, I guess, I can't really explain it because a lot of the principal diagnoses from trauma diagnosis list don't make any sense to me. But the concept is that you've got to have significant trauma from disparate trauma body sites to be able to consider it multiple significant trauma. And then the most significant present on admission injury will be your principal diagnosis. And again, I can't really imagine that a patient would have a bug bite, get admitted for that, and then fall and break their femur, and then pull out their Foley so they have urethral trauma, and now they're in a multiple significant trauma body site. But whatever. So and one of the things you do have to understand is that since your DRG is calculated at the end, you actually can end up with not present on admission trauma entering into the calculation. So for some reason, like if a patient has a Foley catheter and they pull it out and they have urethral trauma, that will count as significant trauma, and that can actually take a patient into this DRG. And these are the multiple significant body sites. And the point is, you want to make sure that all injuries are recorded and coded. And traumatic injuries, you need to make sure that they're admitted into the record. When you see documentation of an injury, you should presume if the patient is there for multiple trauma that it's traumatic, unless it's designated as non-traumatic. I think that you should consider that they think it's significant because the reason they did that x-ray was because the patient injured their wrist. So it's significant. And then again, it's important because you want to make sure that you get all the body sites discovered. And then unless there's a subsequent fall or some reason why it should be POA-N, it's probably POA-Y. One of the things you do need to know is that CCs and MCCs may be nullified if the secondary diagnosis is putting the patient into the multiple significant trauma DRG. You are allowed to use radiology to further specify the injury documented by the provider. So if they say that the patient has a right wrist fracture, you can get the details like a closed Smith's fracture of left radius if that's documented in the radiology, if they've documented the injury. You should try to get the providers to document the Glasgow Coma Scale components, even though sometimes they will be considered integral to the S06 is the head trauma category. Right. Sequencing for multiple fractures is according to severity. So it was an operative, was it open or closed, were there associated injuries like vascular or nerve injuries, and then it could be a judgment call. So you may have to, you as a CEDIS may have to go ask the doctor, which do you think was the most important? Remember that if there's a principal procedure that's a major procedure, the principal diagnosis probably should correlate with it because you don't want to end up in one of those weird unmatching things. This is a place where CDI really can be helpful because when the doctor documents, they're trying to describe the situation, and they may not recognize that whatever they just said has no codable injury that relates. So if they say obliteration, it codes to stricture, and if that's not what they meant, you may need to query them. If they say something like through and through injury or mangled, that's not giving you something that you can capture, and it's probably important to capture it. Organ injuries, there's severity that enters into it, and it may actually change the CC or MCC designation if they're not nullified. And so you may need to ask the provider, and they may look at you and go, I don't know what you're talking about. I told you it was a massive, laceration of the spleen, which to them obviously means major, but you may need to explain to them why it's important. Enterotomy means whole intestine to them, and there is no code for that. So you may need to ask them, like, was that a gunshot wound to the small bowel? So a fasciotomy can be either done prophylactically or therapeutically. And you need to make sure that they're documenting a condition that explains why they're doing a procedure. Okay? So you need to make sure that they understand that there's a fasciotomy, just so you know, is an incision through the fascia that releases entrapped muscle. So it could be a crushing injury that would cause it. And a crushing injury can actually either cause them to do either prophylactic or therapeutic. But what I can tell you is if your encoder takes you to an M code from the documentation, you've gone to the wrong place. You need to go back and get the traumatic version of it. So there's a traumatic rhabdomyolysis and traumatic ischemia. You need to make sure you get those codes. If your doctor says something like ischemia, ischemic limb, muscle is dark or dusky or purple, the patient has the 6 Ps, they're telling you that the patient has traumatic ischemia. You need to go of muscle, and you need to go get that verbiage. Similarly, when providers document things like exsanguinating hemorrhage or bleeding or instituting massive transfusion protocol, they're trying to telegraph to you that the patient has hemorrhagic shock. So you need to look for your acute blood loss anemia. You need to look for your hemorrhagic or hypovolemic shock. You need to see if there's any sort of bleeding disorder or coagulopathy. You need to make sure you have a diagnosis that's actually causing the bleeding. This is a condition which I actually kind of like this one. It's a CC, and there's a coding clinic that basically says, okay, the provider is never going to say hemorrhagic disorder due to circulating extrinsic anticoagulants. I can hardly say it. It's really hard to pronounce. But if you get them to document the coagulopathy due to the anticoagulant and the fact that the bleeding condition is being complicated by or worsened by that coagulopathy, then the coding clinic has said you can compliantly pick up D68.32. Very quickly, incidental pregnancy is very rare. You almost always get an O code first and then something that describes the rest of what's going on with the patient. This would be a situation where you might actually get an incidental pregnant state. So basically, they asked for a pregnancy test in addition. The OB code goes first, and then this is an example of how you use as many codes as it takes. So the first code is injury, poisoning, and certain other consequences. In pregnancy, first trimester. Well, what is the injury, poisoning, or certain other consequence? It's poisoning by heroin. Well, if it's poisoning by heroin, is it accidental or intentional? Okay, it's accidental. So you've got that code. And then what was the manifestation of the poisoning? Well, it was a toxic encephalopathy. And finally, all right, first trimester, how many weeks gestation? This takes 4 codes to tell you all the details. But if I take this abstract and I add water to it and try reconstituting what happened with the patient, it's very easy for me to do that because I have all the information I need to know. All right, sepsis, you have to talk about sepsis, and we're going to talk about it for like a minute. And if you want more than that, you'll have to listen to a sepsis talk of mine. There is only one definition now. It's life-threatening organ dysfunction caused by dysregulated host response to infection. It is the condition formerly known as severe sepsis. And you should get your providers to document it in a way that R65.2 can be picked up. I make a macro that says sepsis due to, and then infection, with acute sepsis-related organ dysfunction as evidenced by, and then I write the organ, and then I do the organ dysfunction. This gives the pieces and parts to say that this is sepsis, and you give the evidence for the organ dysfunction. The SOFA score can be supportive, and I tell them in the emergency department, it's better to have possible sepsis early and let them rule it out upstairs than have the patient rule in upstairs and have to go back and see if it was POA. And then they need to attend to the core measures. I'm going to talk about COVID-19 for a couple of minutes. So the accuracy is important for epidemiological statistical purposes as well as reimbursement. Okay? If the patient reads the textbook, a provider can diagnose COVID-19. The fact they say it is sufficient. And if they're going to do it, I think they should say something like COVID-19 by clinical judgment. But the problem is, number one, there's a 30% false negative rate, so that even with a negative test, you may have to explain why the test is negative. And there's actually new requirement in that the patient, if the patient gets admitted with COVID and you want the 20% upcharge, you need a test. So the ED is a good place to start the test, and then it can come back. And then if you have a pending PCR test, the American Hospital Association and the HEMA recommend that you bill hold, and in the emergency department, that may be a patient that actually gets discharged home. So you may have to contact both the patient and the provider. I mean, you wouldn't obviously contact the patient, but the patient may need to be contacted, and the provider may need to know so that they can improve their judgment. So what kind of things should you be doing? You should encourage them to do the manifestation, interpreting their signs and symptoms. So cough, fever. Do you think it's acute bronchitis? Do you think that this is pneumonia? And there's going to be new codes coming out for COVID-19 January 1st. Stay tuned. You want the linkage. Remind the doctors acute hypoxic respiratory failure. They shouldn't just be saying in respiratory distress and hypoxemic. Give us acute hypoxic respiratory failure so we can capture it. ARDS. You can't do respiratory failure with ARDS because it takes respiratory failure to diagnose ARDS, so it's therefore integral to. And then the usual comorbidities. So I think we have a couple of minutes, and I have a couple of examples. So this is a male presenting from a nursing home with complaints of low blood pressure. They were diagnosed a few months ago with pancreatic cancer. Noted to have a very low BP this morning and was 84 systolic on arrival. Repeat is improved but appears quite dry. Complains of pain associated with the cancer but no other complaints. Here are the vital signs. The patient is tachycardic, tachypnic, hypotensive, and they appear acutely and chronically ill. They're jaundiced. They have crackles. They have tender epigastrium with possible guarding. Their laboratories studies are deranged. The CT to abdomen shows a perisplenic abscess. The patient was given IV Invans and fluid boluses, and the code status was discussed. And then it should be noted, there was, in the ED course, it should be noted that there was an extravasation into the right chest wall, so they were given treatment, but they're not complaining about it. And the clinical impressions were pancreatic CA, hypotension, dehydration, and tachycardia. So I'm going to give you a second to think to yourself what you would do about that, and I'm going to show you what I would do. So this is how I would document in the emergency department. Septic shock due to pancreatic abscess, so due to infection, with acute sepsis-related organ dysfunction of hypoxemia, hypotension, thrombocytopenia, AKI, and lactic acidosis. Stage 4 pancreatic cancer, so there I give the specificity, hypernatremic dehydration, severe protein calorie malnutrition, CT contrast dye extravasation into the right chest wall, so this is a complication, and I note that they're full code. Here's another one, intracranial hemorrhage, transferred from an outside hospital. They were brought to the outside hospital unresponsive and intubated for airway protection. CT showed a large hemorrhage with a right basal ganglia of the right basal ganglia with interventricular extension and 9 millimeter to right to left midline shift. Patient has ejection fraction of 35%, unable to obtain further history due to altered mental status. Patient is obtunded on the sedation. They're on the vent, and then they have posturing. And the diagnosis is only intracranial hemorrhage. So to me, I would be, if I were sitting in the ED with the doctor, I would be talking them through some of this. And I would say, well, what does that midline shift on CT mean? And this would be an opportunity to teach them about brain compression, right? And then the neurostatus conclusion, do you think that this patient was comatose at the time, or do you think that you can't tell? Because it's possible that if you have them sedated, you can't tell, but they may have been, if they look at the patient at the outside hospital was unresponsive, I believe they're in a coma, they can do that. And then airway protection is one of those things that I used to teach because I wanted to explain to them that it's really just basically tube to inside, but you don't really need to give oxygen or ventilation. And then this is an opportunity to ask the doctor, do you think that there's D68.32? So do you think that those circulating extrinsic anticoagulants of Plavix is contributing to the case? And then the last one is GI bleed brought in from local rehab where they're there for CHF, sent in for rectal bleeding, started a bunch of fluids, low H&H, a liter of blood per rectum, spoke with intensivist, accepts patients, then the patient is made DNR arrest, blood pressure is originally 124, goes down to 59, 72/38, level of consciousness improved with systolic blood pressure 90s at the time of transfer. So this is a documentation, right? Well, they called it GI bleed. And so the opportunities as a fetus would be to educate them that if you know the etiology of GI bleed, which may not be possible in this patient, but it may be that you're educating to prevent a query in the future. It's best to do that because that actually helps sometimes. Hemorrhagic shock and acute blood loss anemia. Is there a diagnosis that goes along with the abnormal creatinine? So teach them about AKI. And if you documented that the level of consciousness improved, that says to me that it was bad in the first place. So did you think that there was encephalopathy? So obviously you can't lead them. It's not compliant. But find a way to get them to understand what you're asking them without leading them there, and then get them to make a decision. If they need information, you need to do education. So we've actually talked about the objectives, and I hope that I've done those for you. I hope that we've done those. I did want to let you know that I do have a module on clinical documentation in ED, helping your hospital, helping your group, which actually teaches the doctors most of what I just taught you, so that if your CDI group is interested in having this presentation for them, your institution can actually purchase these modules for your doctors so that you will have them starting at a place where they understand you when you start doing CDI with them. And I have some other modules. You guys can check them out if you'd like. So at this point, I'm going to ask, I don't know if we have time, and do we have any questions?
There is time for a few questions, and if you guys would put them in the chat box, that would be great, and then Dr. Reamer would be able to address them. If you think of them later, we can always send her an email with your questions.
Well, if there are no questions, I am going to say to you guys that I wish you a very happy CDI week. I know that this is the end, but you still got a couple of minutes left to the day. And I would like to wish any of those of you who are celebrating the Jewish New Year, I would like to say to you, Lashana Tova. Thank you very much to Indiana Actis for having me. It was a pleasure. I wish we were in person, and maybe next year we'll do this in person. So if there are any questions that come in, please feel free to forward them to me. And if anybody wants to ask me any questions, this is how you can reach me. Thank you very much for having me.